Hi, good afternoon, everyone. Can you able to hear me and see me?
Yeah, it's clear.
Thank you so
It's
much,
good.
everyone, for
Good
joining.
afternoon.
Very good afternoon. So, feel free to switch on your cameras to show your beautiful and smart professional faces anytime. And we'll start this meeting with today's agenda. Uh, we have in our meeting the main contributors is going to be Dr. Liza Hassan, who is Quality and Organization Excellence Director from Al Salama Hospital in Jeddah. We have Dr. Kavita Balikar, who is the Chief Nursing Officer in Reem Hospital, Mamin. Mr. Arun Govind, who is Chief Executive Officer in for ARHC Consultants in Bahrain. We have RAGHVI Damodaran, who is a Quality Manager in Royal Bahrain Hospital in Bahrain. And then we have Dr. SAMIA Filali, who is the Quality Director for Royal Healthcare Group, which is also based in Abu Dhabi. My name is DEEPINDER. I'm working as Regional Senior Manager from Patient Safety and Quality Division for NMC Healthcare Group. So it's great to connect with all of you. We have our agenda today, and the first point will be to consolidate the group objectives. We will be having discussions on the new healthcare regulations in GCC, what is coming up. Then we'll have a session on the trends, which is from AI, IoTs, and genomics. We'll have two success stories today. And finally, we'll be summarizing what are the upcoming regional and international awards from the perspective that what see. So now, before we start, I have a short survey which I request all of you to take up. If you can just see the chat box, there will be a link. You can click the link, or if you feel it's more comfortable for you to browse through QR code, we have a QR code. You can scan the QR code on your screen and then you can participate in the survey. What I need to know is that what is your primary expectation from this professional group? So basically, what I request is that in one word, uh, what is your expectation? So it's knowledge acquisition, sharing of knowledge, updating current trends, advances in AI, networking. Yeah, that's important. We have seven participants. Once we have 30 plus, we will summarize what is the most important thing. Networking is coming up. So number one is networking. Number two is current trends. So feel free to scan the code, or you can definitely see in the chat box if you are using mobile phones to participate in this. So the biggest word what we see is networking, and that's important. I just wanted to make sure that we are all on the same page in terms of what we are trying to make sure we deliver in this group. So the first point of this agenda is going to be what are the group objectives. Let's consolidate that. So as you all said, learning, yes, that's the primary aim of this group. We facilitate through continuous professional development. It will be discussion, there'll be webinar, there'll be resource sharing, which you already are part of it. Innovation, yes, we have received a lot of people from the past from different countries, different backgrounds in terms of what is our innovation coming up in this field. Networking, yes, in the Middle East, it's a good platform to connect and share the information. That is also about exchanging the ideas, the best practices, and any industry updates. And finally, support and mentorship. This is to provide guidance and peer support. So they are the group of the profession that we have. Uh, Everybody may not have reached the leadership level. So some of you are working in a top leadership position, some of you are not. But idea is that everybody should move towards that direction. So what we have consolidated is that we called it as links. Okay, LINKS. That's what we look forward to contribute and make our objectives stick to. Uh, there was a discussion this morning and earlier also that whether any advertisements or any sort of promotions are going to be part of this group. So frankly, I need to uh, inform that, you know, some of you have objected to it that we should not use this platform for any marketing or advertisements. So we have just restricted that as of now. But we'll see how does it go, and if there's any information which is really important for everyone, probably it'll be send it to all of you individually through maybe a different type of platform, in the sense like it will be direct sharing of messages or in a different way. Okay, but I hope you are all okay with that. Okay, we will be sticking to these goals and objectives. If you have any questions, anybody wants to have any suggestion on that part, anything we should add, please feel free to speak out on that. Anything? Okay.
No, it's good.
So thank you so much. Great. So let's go to the next point of today's meeting. So
You
new
can
healthcare
change your
regulation.
slide.
Uh,
We
sorry.
are seeing the Slido slide.
Oh, sorry. I'm so sorry. I did not realize that. Thank you for pointing. Otherwise, the full presentation would have gone like this. Okay. You can. Okay. So you have not seen this part, right?
Yep.
This was the first point what I just mentioned: learning, innovation, networking, knowledge sharing, and support and mentorship. So these are called links, and this is what we are going to sticking forward to. Can you share the? Can you see the screen, right?
Yes.
Oh, perfect. Thank you
Yes.
so much. Great. So now moving on to the next one is new healthcare regulations. So first, we'll be starting from what is coming in UAE. So in UAE, there was a recently one session from Department of Health about the Moasher ranking. So Moasher is a system which was launched in 2018, and just recently they have come up with Moasher ranking system, or maybe Moasher version 2, in which they have taken some parameters on the dimensions of what our hospital are going to be measured on. So these are the KPIs what will be monitored in terms of four domains. So mortality, readmission, timely or effective care, and safety of care. So these are the something which they have come up with. These are standard. You may not see anything new except for few in terms of putting up the KPIs. But what is going to be changing is that these are going to be measured, these are going to be evaluated, and not only this, the validation of the data will be very important, which will determine what payment mode the hospital is going through. So this is a system which they are coming up with to ensure that every hospital performs to best of its abilities. And also in terms of KPIs, earlier it was like, you know, till date also, all the KPIs have to be manually entered or manually shared with them. So now it's going to be automated. So directly these things will be picked up from the electronic medical records and most of the other information what is available with the hospital, and it will be directly relaying to the service of MTOH. We move on to the next one. There's an update from Saudi Arabia, and I will request Dr. Liza to take over now. Dr. Liza, over to you. Just your introduction first, and then we can.
Hi, everybody.
Dr.
Can
Liza,
you hear me?
yeah, there was an echo. I think there are two devices in the same room. If you can just
No.
turn off one. Or maybe from anyone else. I'll
No,
request
it's
all
not
of you
from
to. Yeah, I think it's fine now. Yeah, Dr. Liza, please go ahead.
Okay. Hi. Hi, good afternoon, everybody. I'm glad to be here with you in this presentation. And thank you, Mr. Devender, for giving me this opportunity. I'm an anesthetist, intensivist in my background. I'm a ACHSI surveyor. I'm in the field of healthcare for the last 33 years, 20 years out of them in quality and management. I'm CPHQ certified, Green Six Sigma, Master in Strategy and Leadership. So before I start this presentation, let me. You can hear me? There is echo. also?
Yeah, we can hear you.
Okay. I will start.
Sure. Thank
Yeah.
you.
I think all of us, we know how the Kingdom of Saudi Arabia are moving forward to the vision of 2030. And out of this vision is working on the healthcare. It's one of the part of the vision of 2030. So part of it, we have the CHI accreditation. Before I start the presentation, I'll go through different definitions which will be used in this presentation. The word CHI is for Council of Healthcare of Health Insurance. SIBAHI, I think most of you may be aware about it, is a central board for accreditation of healthcare institution, which is a national accreditation. Nafis is a platform, electronic platform, is used for the insurance and exchange services between the hospitals and the insurance company. And it's one of the strong platform in the kingdom. HIMSS, again, all of us, we know about it, Health Information System, Healthcare Information and Management System Society, which part of the accreditation of many organizations. So next. There is echo. Yeah. Okay. This CHI is developed in order to bridge the gap between the provider, the national standards and the insurance. So as we know, in the SIBAHI, there is 7 domains. It's leadership and quality, medical service, nursing, infection.
Just a second. I'm just muting everyone as of now. I think by mistake, some of us are there. Dr. Liza, just unmute yourself and then you can start. I'll just reshare my screen. Yeah.
Okay. So I was talking about the SIBAHI. In SIBAHI, we have 7 domains. It's covering leadership and quality, medical service, nursing, infection control, medication management, laboratory services, and facility safety management. So the CHI came in order to cover the other parts, which is related to governmental requirements, RCM, revenue cycle management, and operational excellence and healthcare information management. Next. So what is this accreditation is about? As I said, you have 4 elements or 4 domains in it: governmental regulation, organizational excellence, learning and sustainability, and quality beneficiary care. They categorize the hospitals based on their achievement. If they get the score 70, they will be a learning organization. If 80, it's improving. 90 in advanced level, and 100 outstanding, over 100, which is 110, is the market leader. The reason of this categorization is to it will be later on the payment methodology and the value-based care. It will be built on this one. That means this class A, B, C, D, the class of the hospitals, and the payment it will be depending on this categorization. This, for the time being, is going under revision, and maybe within the coming months, it will have, they will release the exact definition for each one of these. Next. So the same like any other standards, they have standards, substandards, and intent for each standards, and what are the evidences related for the compliance, and the references from where they get these standards. So if we will go through the standards, we'll see how it look like. Okay, next. The standards is divided to 4 domains. The one is related to revenue cycle, RCM, health information management, then operational excellence, and governmental requirements. If we will go one by one, it's they are talking in the previous one. Yeah, approval and revenue cycle, we are talking about the resources required and beneficiary rights and experience. In this regard, they have another accreditation for the health insurance company also to be aligned with these standards. Under health information management, as I said, NAFIS, which is a electronic portal for communicating between healthcare organization and the insurance companies, data governance, and all the related issues related to data governance, security, and all this issue, AMR, business continuity plan, and accreditation for HIMSS. Operational excellence is focusing on population health program, where this has become a crucial part of this accreditation. The other one is value-based care, which is, I think, the new trend in all organizations. But the focus here is about linking this one with the payment module later on, as I said earlier. So governmental requirements also, it's related to you need to have the MH license, CBAHI license, and other as required, because the more license you have as HIMSS or any other licenses, it will raise the level of your score in this accreditation. Okay, the scoring system for it, if you have full compliance, 10 points, partially compliance 5, non-compliance 0, and if it is not applicable, there will be no score and it will be removed from the total score. And this is a booklet of the accreditation, and we can I can share the link of it, and it's available on the in the website. Next. So I will go through this one, but I will go through it very fast. We can share this presentation with all of you. These standards is covering, as we said, revenue cycle management, and these are most of the standards will be applicable. They choose in the last 2 months, a few of them to be optional, and some of them it can be not applicable based on the organization. But final version, it will be released in this month. So it will talk about all the details in each part of the standards, and if you'd like, if there's any time, I can go through them, or it's okay, I can share it. Yeah.
It's a chapter, like, you can just mention what are the chapters names, yeah.
Yeah, it's here about health information management, and it's covering all the things related to health system, related to data, how it's managed, and the regulation related to it, how to protect the data, security of the data, and integrity of the data, and all related policies. This is okay. The last chapter is related to all the required licenses by regulations, MOH, and other government-related regulation. I think this is in brief what is the CHI about, and which is in this year it's become mandatory for all organizations to start complying with these standards.
Great.
This,
Thank you,
I think
Dr.
I
Liza.
conclude my presentation. Yeah, thank you.
Thank you so much. Thank you so much. And it's a very interesting thing that in KSA and also in UAE, the value-based care is being populated. And I think this is same trend is coming up in other countries also. So that's interesting knowledge, and that's a way forward. Thank you so much for your insights on this, Dr. Liza.
Thank you. Thank you.
Great. We move on to the third part of today's meeting, and that's about upcoming trends. And I'll request Dr. KAVITA to have a quick introduction and start her presentation. Over to you, Dr. KAVITA.
Yeah. Good afternoon. Am I audible?
Yeah, I'll just reshare my screen to include the audio. Yeah, you can just start your introduction already.
Yeah, okay, great. So good afternoon, everyone. I'm Dr. KAVITA Bhalekar. I am the Chief Nursing Officer with WAMID, and I have around 22 plus years of healthcare experience in various positions, which are there. And my expertise and passion is in hospital operations, projects, performance, and patient care excellence. I hold a PhD in nursing, and I'm also a fellow from the American College of Healthcare Executives. I have a CPHQ and an MBA in healthcare, and I'm proud and happy to be part of this team and to share the trends that are there in healthcare, which we all need to know, definitely. So, because that keeps us going and keeps us moving, definitely. So the content, in short, it is the key drivers and all the points that I have put that we can be seeing in the coming years. It's not very far. It would be definitely coming in. So what are the drivers? Basically, the drivers for global healthcare industry, first and foremost, is the technology advancement. As we know, the revolution has happened, and it is now we are come to 5.0. It was 1.0, 2.0, 3.0. Now we are gone to 5G. Now, if it is 5G, we all need to be adaptable because our next generation is coming in. We have the millennials working with us, and they are not going to be working on paper and pen. So definitely it has to be a technological advancement. We will be having aging population with us who we need to take care of. There's consumerism of healthcare where patient is the center and the patient is driving. And we have government initiatives and globalization of healthcare. We have seen a lot of movement of patients trying to get the best of care, whether it's in Middle East, Singapore, whether it is US, UK, patients are trying to venture out to get the best in the healthcare. Next, please. So this is the lineup of all the topics that we are going to be doing and what are the trends that have actually emerged and are going to be emerging and going to be much more advanced into the technology. Next, please. Yeah. So the impact in the healthcare industry of current, how these are placed is we have artificial intelligence, which has taken around 18% of it. Internet of medical things is 17%. Telemedicine comes 12%. Data analytics has jumped and come up till 11% because it gives us a lot of information and evidence-based practices. We'll be looking at each of these into detail. Immersive technology again shares the same platform with data analytics 11%, 3D is 7%, mobile health 8%, blockchain 6%, cloud computing and genomics share around 5%. The next slide, please. Okay, so coming up with these all technologies that we have. So the first one that I would like to share is AI and robotics, which is very simple. We'll start from simple to complex. So first and foremost, we all know about the AI because we all are using definitely EMRs, which have these all built-in products into it. And we do have all these points. So we have chat box, we have the vital information, we have the internal communication, the patient can get an information right away. It shortens the length of stay because it uses a lot of algorithms, inbuilt algorithms, that is the clinical pathways can be and clinical guidelines can be inbuilt. So if we have Cerner or you have the Epic or you have InterSystem, you have any of these systems, they all work on based on logic. So that is what is AI. Basically, they work on the logic and therefore lowering the readmission and do a better data management. Next, please. So where all it gets application is present for this AI. So this is just in a small nutshell that I have tried to present it, but it can go much beyond this, where the applications of AI can happen. We have advanced or enhanced diagnostic, remote patient monitoring, personalized treatments for the patient. You have predictive analysis where disease outbreaks can happen. That's what COVID they did actually, and they were able to predict and to say when later on in the stage, not in the first 6 months or anything, but then the all data when it started coming in, they were able to tell us how and where it is spreading, why it is spreading, what are the measures that we need to do. That was analytics basically. So drug discovery, development, it reduces the health costs, enhances data security, language translations are definitely improvised. And there is even a Samsung phone, like yesterday, there was information on the radio saying that the new Samsung phone actually helps you to convert and converse in real time in 6 different languages. So that is AI. That is how big it is. So why, when it can happen on a phone, it is not very long that it will start happening even in our EMRs, right? So that is what we are looking at. Deepinder, can you play the video, please, for me?
Sure.
The sound.
Uh,
The sound.
Prevent harm.
you can hear it
And
now?
protect
You can
your
go back.
caregivers and
Yeah,
patients.
yeah.
Sure.
Thank you.
What if you could use the power of AI to predict problems, prevent harm, and protect your caregivers and patients? At Care AI, we make care facilities smarter. We make care environments safer. we help care teams be aware and prepared so they can do what they do best. Provide more timely moments of care with a human touch. Care AI, powering more human care.
Okay, this just a disclaimer. I do not have anything with the company. This was just to enhance and to show that how it is becoming more that AI is going to be having, and the virtual hospital that is going to be coming and using the technology. The next slide, please. So talking about AI and the virtual technology, this is Sarah. You need to meet Sarah because she is the new resource assistant by WHO. If you go to the WHO website today morning, which I saw, was this good lady named Sarah who is there. She's a chat box. It is a prototype of digital health promoter. She is available 24/7 and uses 8 languages, either in video or in text. And WHO has utilized this virtual assistant to provide tips for de-stressing, for eating right, for quitting tobacco and e-cigarettes, okay, as well as to give information on other health topics. However, she is not designed to give medical advice. So these are health virtual assistants which will be coming and will be useful in the mental health. Just imagine how much it is going to help in decreasing or improving the health for the mental health people, the chronic disease, the eating disorders, the quitting of tobacco. I mean, people do not are ashamed to go for asking for help. So this, they can do it on their own. And if they know, and we can propagate saying that there is somebody whom you can talk to without the disclaimer or without having a stigma attached to it, it will be very useful. So virtual assistants are coming. We have seen virtual assistants when you go on any of the website, there is a pop-up which says that, how can I help you? And they ask you leading questions, right? In the same way, we can use these virtual assistants in our EMR in order to be able to streamline the appointments of the patient depending upon the symptoms that the person gives, right? So the call center can be useful. There are so many areas where virtual assistants can be definitely helped too. So these are the ones which we can utilize, and we should be proud of in having it on our EMR if we are a smart hospital. So this is what was done by WHO. I just seen it today on the website. Maybe all of us, those who are on the call and those who are healthcare leaders, should definitely be utilizing this. They have also asked the healthcare leaders to do a small survey. So please try to get onto the WHO site and do this survey, please. Next slide, please. Okay, coming on to the next one, that is augmented reality, virtual reality, and mixed reality. Okay, now what are these? Virtual realities are projected medical images onto the patient's body, which help the doctors to make diagnosis of a condition of the patient. Okay, that is augmented reality. Sorry, my bad. I mentioned as virtual. It is augmented reality, which projects the medical images of the patient's body. A virtual reality is wherein they put in those devices or the Googles, and then you are able to see or stimulate a surgical procedure wherein the doctors can actually see the procedure or on the imagination or virtually before they actually perform it on the patient. The same way, we can also use virtual reality for patients for guided imagery. Okay, so I'll come back to that part of it. But yes, virtual reality is that. Mixed reality is a mixture of augmented reality and virtual reality together, wherein you can have immersive information. So if I play this video, Deepinder, can you help me to play this video, wherein you will be able to see how. Yep. Here you will be able to see how the students are learning with the help of virtual and augmented reality. So it's a mixed reality. Go ahead.
Get the full 3D experience of a cadaveric dissection without the cadaver using AR in complete anatomy. Hit the AR mode button to get going. Move your device slowly up and down to find a suitable plane. Tap to place your model. You can rotate the model by dragging one finger across it or adjust its position using 2 fingers to pan. Slide the scale bar along the right-hand side to adjust the model size. When you're ready to share your dissection, hit the Start Classroom button on the top right of the screen. Other users within range can activate AR mode and join your classroom to see your dissection. They simply place the model in the same position as the host to see what you see. A list of participants will pop up on the right of your screen as your virtual classroom grows. With the model in place, they can now follow along as you, the classroom host, take them through the key features of your dissection, just like you would in a lab. Challenge your students to identify the important structures on the model and then tap it to reveal its name and description. With multi-user AR, you can benefit from views that are not possible with traditional dissections, such as exploring a live beating heart.
Yep. So how did you find it? Immersive, right? Immersive. Definitely, it gives so much of information to it, and teaching becomes so good. Okay, so teaching becomes so good. And imagine if you can use this technology to teach your patients. Like, for example, use of inhalers, use of diabetes pen, use of exercises, so much of information that we can actually give to our patients so that they do not come back because of any kind of complication or readmissions are decreased. So mixed reality can be utilized in different manner. Next slide, please. So this is how actually it is the augmented reality or the virtual reality, which I can say. For example, you can stimulate a medical procedure. So when you're talking to the patients, you can actually show them, okay, fine, this is what is we are going to be doing with you. This is how you will be taking your medication. This is what you will be seeing. Even vein viewers, right? Vein viewers are what? I mean, basically, they are the AI devices wherein you are able to see the vein below, and it's one of the tool that is for nursing, because the first procedure that we do for the patient is insertion of IV cannula, and the last thing that you do is remove the IV cannula. So that is why you require augmented reality, or you require these kind of things to be helpful in the medical field today. You maybe when we were in school, we used to use guided imagery for psychiatry patients, right? Wherein the teacher used to tell us to ask the patients to close their eyes and say, okay, now please everybody close your eyes and think that you are on a beach, the water is touching your feet and you're feeling good, you're happy, the breeze is flowing, right? So that is what was guided imagery. But now you have something which is a virtual reality, wherein the patient can actually go and see, have a mixed reality and a mixture of vision as well as the feel together. And it actually helps in treating Alzheimer's, it helps in treating mental disease, it helps in treating pain. It also helps for pediatric patients when we are doing cannulation. If you give them the virtual Google, they are definitely into a Tom and Jerry cartoon, and you can actually do a good IV cannulation for them. So it actually eases pain and it treats dementia also. So this is one of the best tools that technology can give and can be helpful for patients. Even if it is momentarily, you can relieve symptoms, and it really is wonderful. Next slide, please. So coming to the Internet of Medical Things, okay? Now, Internet of Medical Things is all over us. It is right from our mobile phones, right? These are all the wearable devices that we have, okay? Whether it's a mobile phone, whether it's a necklace, whether it is a smartwatch, whether it is sensory patches, all this is together is called as Internet of Medical Things. What does it do? It pulls in all your information, all your data onto that app, or to wherever it is logged into, whether it can be on your own mobile, or it can be in the hospital with the hospital's login. It can be in the cloud. Okay, so what it does is it basically provides timely diagnosis. Okay, because it is measuring your heart rate, your blood pressure, the blood sugar, all those things are connected. Your height, weight, body, your steps calculations, all these things are actually inputted in that along with all these devices. It improves the patient engagement, because every day you see, oh, today I did only 1000 steps, no, I need to do more. And that engages the patient. Oh, I did 10,000 steps today. Have you heard this? It's very common nowadays. You hear many people saying that how many steps they have done. That keeps them engaged, keeps them going. It is wonderful actually to see them engaged in that way. clinical trial participation becomes very, very easy when you have wearables, right? So that the patient is not stuck inside a clinical lab, and patient can do their own things, but yet still the monitoring is going on. So hence clinical trial participations have become really very rampant and has increased because of the Internet of Medical Things or wearable health devices. Next slide, please. So this wearable devices has now helped in telemedicine to change on to becoming 2.0, because with the help of this wearable devices, it has improved accessibility to health, it has reduced cost, and it has improved self-care, right? But in telemedicine, how has it helped? It has helped us to decrease our routine checkups and follow-ups, right? So when you get all the information from these wearable devices on the mobile, and that mobile will be connected back to our hospital EMR, we will be able to know the patient's blood pressure, the vital signs, the steps, the ECG, the blood sugar. So that will give us the information whether the patient really needs to come or patient does not need to come. So follow-ups can be decreased, routine checkups can be done on telemedicine, primary health can be delivered, so that we just send the prescription back to the patient. Nearly around 40% of the hospital visits can be cut short to actual care that is needed for patients, because many a times our emergency or urgent care is all full because of these routine checkups and follow-ups. So we can free the doctors or the physicians with a telemedicine setup separately to, and the doctors in the hospital can actually pay attention to the patient, those who are in the triage of around 1 and 2 and 3. So 4 and 5, we can keep them for the telemedicine. So that kind of a juggle, each of the healthcare workers can actually do it for them. Okay, so chronic disease, mental health, primary care can happen. So robotic process automation. Okay, robotic process automation is all those steps in the hospital which are routine and monotonous. Okay, like for example, the call center. Okay, in the call center, what is it that the call center needs to do? What is the billing needs to be done? What is the patient scheduling happening? What is the employee, not the employee, the patient response to the treatment plan which is there? So all these processes which can be automated is called as robotic process automation. Okay, at present what we are using this is in order to decrease your labor cost. Okay, so that you don't need a lot of labor. Now, for example, if you have the virtual assistant, will you need a big call center? Will your call center have 10 people? No, because your virtual assistant is actually going to be working 24/7 and is going to take in all your calls which are coming in and is able to give. You may not need 10 people in the call center. You may need only 3 people in the call center. The remaining can be happened by your virtual assistant, right? So it all depends upon the service that is being provided, the which service you want to automate and how you want to automate. Whether you want to automate the billing process, you want to automate the patient scheduling process, you want to automate the EMR, the electronic medical records also has automation. Like for example, if we have got a patient with chronic disease conditions and we have clinical pathways, we all have got templates, right? If those templates are the ones that is called as automation. Why? Because we all just fill in the templates and please and keep moving in front, because we know for sure that you need to hit 1, 2, 3, 4, 5 points in order to complete your billing, as well as to able to give a good comprehensive patient care, like improve the patient quality. So that's wherein the robotic process automation comes into picture. Next app, the trend that can be seen is mobile health apps. How many of our hospitals have mobile apps? All have, right? It has become the need of the hour. If your hospital doesn't have an app, you are not smart hospital. That's what they say, right? So each and every one of our hospitals definitely need a mobile app, because that keeps the patient engaged and keeps the patient in charge of taking care of their own health, as well as if they want to do any appointment with whom they want to book, if they want to see their reports, if they want to put in a consultation, These are all things that are currently available on most of the mobile apps. Okay, what are the other things that can come in? Sorry, can you go back? Yeah, what are the other things that can come in along with mobile apps is the testing, remote health testing, which actually became very rampant during the COVID, right? In COVID, we all saw the app that was put in by the government and how that helped us. Then comes the digital therapeutics, wherein you can have customizable tool only for that patient. You will activate that module, wherein you will tell the patient definitely, okay, this is your care plan for the next 1 month. You need to do 1, 2, 3, 4, 5 for this next 1 month. Your visit will come after a month, and that is called as digital therapeutics, wherein you customize care for that patient on that mobile app only for that patient, right? Okay, next. Big data and what is the use of big data analytics. Big data analytics, when we all are talking about all our information going on one platform, it is taking all the patient data. Now imagine if we are having say around 2000 patients coming per day. Imagine the amount of data that has been collected per day. I'm talking only about, okay? So if around our hospitals are seeing around 2000 per day is one facility, about the next facility, imagine the amount of data that has been collected. That whole data needs to be churned to give us meaningful information, and that meaningful information is your evidence-based practice. The evidence-based practice, for example, door to balloon time, how did it come? How did they say that it has to be less than 60 minutes or 120 minutes? Then only the outcome of the patient is improved, right? So this information came after we had this big data analytics, which was done on a very larger scale, global level. Basically, HbA1c monitoring should be done only after 3 months and not before 3 months. Why did that come up? Because of all this information that has been collected. The other success stories is like basically they were able to bring in oncology drug segment. A new product was utilized only because of this kind of big data. Readmissions were decreased when you cohort high-risk patients. The hospital can improve profitability by 5% if you start looking into your data. You have data on different kind of platform. You have operational data, you have financial data, you have clinical data, you have quality data, but that all needs to marry into each other to give you meaningful information to improve your the patient care journey for the hospital as well as globally. Next, cloud technology. So this information, all this information is somewhere on the cloud. So how and why is this important? It's basically because we can now access this information anywhere and everywhere. Maybe some of you are having an iPhone. You may have an Apple Watch, right? If you have an Apple Watch, you have an iPhone, and you have a Mac. Does it talk to each other? Does all your information talk to each other? Yes, it is very It is very, very useful because it is a single platform. So imagine if a patient's information is on that one single platform and it can be accessed by the doctors or by the clinician or by the regulators at any given time. The patient's care will be continuous. Patient does not need to go from one hospital to the other when he has already finished an X-ray in one place, doesn't need to do an X-ray again on the other place. So those who are from UAE, they will know Malafi, right? So the Malafi is something which is actually a cloud technology based, trying to bring in all the information of the patients from different hospitals, which are there on one single platform, and anybody and everybody who is needed. Definitely there are rules and regulations related with the information sharing, that is HIPAA. We should be compliant with it and then only go ahead with the cloud technology. But yes, this is a good technology which improves healthcare and also improves the scalability of healthcare. You can provide care anywhere remotely for the patient, even with the without compromising on confidentiality or privacy of the patient. So better security is needed. Data can be offloaded. There is 24/7 security compliance, and there is continuous patient care. That is the main focus of cloud technology. Next, please. Okay, this is very interesting. This is what I love actually. So 3D bioprinting, this has come in. It is not very new, or but it is not very old also. Okay, now these are artificial bioconic devices which are prepared externally for implants or for artificial leg or hips, eyes, ears, nose, anything that can be actually prepared digitally. So it is called as 3D bioprinting. They are very cost effective and do not need a very long recovery process also for the patient. So this is one which is really very, very good, and it has taken up its own momentum. It, as we said, that there is around 16, I guess around 8% of uptake, which is there because we definitely need this technology. It is a cost effective for the patient side, from the hospital perspective, and from the payer perspective, it may not be that effective as of today. It requires a lot of working to be done on that aspect. But yes, it is something that is seen good results for the patient. Next, please. Okay, coming to genomics. Genomics is basically the next generation sequencing. So where we are trying to target and identify at-risk population. So the patient, those who are at risk, they are a small tiny blood sample is also sufficient in order to know the entire genomics of the person basically, and to improve the quality of life. And also, if those who are from UAE, they will know that IFHAS is one program wherein we are actually doing a comprehensive screening. But along with that, there is also a consent which is taken for genomics. So all the UAE nationals are actually being checked along with the IFHAS program also for genetic testing, so that they can be identify at-risk population first itself, identify the gene, and then be able to give a proper treatment. Genomics goes along with my next slide. Next slide, please. That is nanomedicine or nanotechnology. Okay, nanomedicine, nanotechnology are these particles which actually go and deliver precise treatment with either by targeting the cell tissue, or either by carrying the drug, or either by interacting with the immune system. Okay, so this is a nanomedicine or nanotechnology which is actually going and only hitting those cells where it requires to be treated. So whether it is screening, diagnosis, it is delivery, it is characteristics or synthesis. Most of the diseases till now that it has been used is cancer, diabetes, wound healing, orthopedics, and immunology. Okay, so these are therapeutic agents which actually deliver medicine or carry immune system only to that area. Okay, so that is nanomedicine and nanotechnology. Coming to the last slide, I guess. So in conclusion, these technological advances and booms are definitely going to be there, because it is not going to stop here. Our 5G is not going to stop. It is going to grow. So we all need to be ready. It is all about longevity and health span. I'm not talking about lifespan. It is health span, because each one of us are going to grow old, because our longevity is going to increase, but we need to stay healthy. So that is health span. We are not talking every year about the lifespan or the ages that are going to be added, but the health that we are going to add to the ages, and the drivers are basically longevity and health span. The government, the payers, and the providers are all together looking into it for the greater good of the community. So these are some of the trends that are going to be coming and which I was able to present. If there are any questions, I'm happy to take them.
Thank you,
Any
Dr.
questions?
Kavita. I
Okay.
think that's a good one. Thank you so much for your comprehensive presentation. We will be looking for your answer questions in the chat box from anyone. If they have, just put up in your chat box. Thank you
Sure.
so much. And now we will move on to the next session, and that's going to be success stories. So I'll request Mr. Arun to present his success stories. Yeah, Mr. Arun, we can see your screen. We just need to put up in your PowerPoint mode.
Hi, good afternoon. I'm the CEO of two companies. One is a 11-year-old healthcare consulting company based out of Bahrain, and another is a digital healthcare consulting platform which is under development and 1-year-old company. I'm going to present the success story of American Mission Hospital when I was the chief operating officer there, and we were going through the digitization of the entire clinical governance framework. So I will start the meeting with this particular cartoon. So this cartoon essentially says that humanizing the entire healthcare journey is very important, because if you can see, humanity researches AI, and then humanity perfects AI, and then AI started taking control. AI perfects itself, AI then enslaves humanity. There is a solar flare that disables AI, and then humanity started worshipping sun god. So there are two elements that cannot be eliminated, which is the ultimate power God and the human touch. So it is very important to understand the human element of care while we go through all the AI, Gen AI, the IOMT, AR, VR, genomics, and all those was explained by Dr. KAVITA. I'm referring to an article in McKinsey, which is a recent article about the generative AI and its usage in speeding up the design process of products. So this is from a different industry. So you can see the future museum, how this can really help the visitors having an engaging educational environment with virtual and immersive experience. So you can see the pop-up digital boards that will give them the information about each of these art pieces that is displayed there. Here is another example of iterative prompts by a designer that will enhance the quality of the design of a welding helmet. And the iterative design is stemming out of the sports field, where the design of the helmet is something similar to the helmet which is used in sports. Another example of how an iterative design can enhance the quality of the design or the picture. You can see the 3D effect of the picture on the right-hand side when that iterative prompts are being used by a designer. So my presentation is about the AMH journey. We have gone through this problem of not having the digitized, where data is not available for all the clinicians as well as the other users in the hospital. So what we did is we created the objectives of digitizing the entire CQI framework, then creating an outstanding customer experience. So how to capture that was also created as the objective, establishing a patient safety culture within the organization, and ultimately how data can be captured through live dashboards that will enhance the journey and action can be taken in a faster manner. So we have Dr. George as a leader, who is an ex-Aramco physician. He's a neonatologist by profession, and he has been leading the organization. And from the internal perspective of AMH, he has created this framework, quality framework management system within AMH. So you can see the vision and mission of the organization, within which the balanced scorecard from the financial, internal process, customer experience, and learning and growth perspective, which will lead to the voice of the customer. We have a electronic net promoter score system that will capture the entire patient experience through the net promoter score, which is widely used in many industries for understanding the customer experience with a score. And then the various service line heads are mapped to this voice of customer, as well as to the voice of process, which is the quality improvement plan, which is embedded in the quality improvement plan. And that will lead to the CQI dashboard that will help the management as well as the service line to take decisions based on the progress that is made. And in the same framework, we have the staff NPS. So we also have a completely digitized staff NPS system. Staff competency mapping is also digitized. CUSP, PDSA, risk management, clinical pathway, COR, IPSG, KPI, and accreditation readiness. I'll demonstrate this in the subsequent slides. And we have the outcome and the patient experience also captured in the process. And all of this is done without compromising the compassion, grace, and love, which is what our organization is based on, because AMH is a 120-year-old organization, which is started by the Reformed Church of America based on the biblical principles of compassion, grace, and love. And this clinical governance metrics is created by Dr. George, and he has got an effectiveness tile on the left-hand side and the other elements of the clinical governance on the right-hand side. You can see clinical effectiveness, resource effectiveness, learning effectiveness, and strategic effectiveness. And on the right-hand side, you have the risk management, communication, which is very important, patient experience and feedback, and employee engagement, which is very, very important. So we also followed the DMAIC methodology of QI model, which all of you know. And in the define process, what we did is the voice of the patient through the clinical audit and improvement, employee engagement, learning efficiency, and clinical effectiveness, risk management, and resource management efficiency. So these are the elements that we considered while developing the digital transformation strategy through the digital development. So AMH is a typical healthcare system. Why we say it is a healthcare system is because we have got multiple locations, presence in multiple locations within Bahrain. We have 20 service lines and 15 departments, and we have 1,200 employees. One of the examples of the defining process, how we leverage the technology to gain on the time frame, is before we implemented the system, the audit is done, then data is collected on paper, then translated into Excel sheet, then graphs are prepared, and interpretation is done, action taken. By the time it will be too late, because it will take at least 30 to 40 days. Currently, we are doing a project in Ministry of Health here, and they also face the same situation, that the entire dashboards are created through Excel sheets for 27 primary healthcare centers and 8 hospitals, including 1,500 bed teaching hospital in Bahrain. So once we implemented the digital transformation, we found that it takes only 24 hours, mainly because the entire activities and clinical management is done through the digital platform where live dashboards are available, and therefore action can be taken very quickly before it is of no use to take an action, because patient satisfaction is all gone into negative. The measurement side, pretty much all areas of measurement that is required as part of accreditation or as part of continuous quality improvement through the system. The SOPs and policies metrics is maintained within the system, and you can map all the KPIs related to each policy is being captured through the system. You have the balance scorecard auto-generated from various data touch points. You have the committee meeting minutes auto-generated within the system, either through the voice prompt or through the manual entry into the system, so that action plans can be automatically monitored. All the reports connected to a particular committee meetings can be opened through the system. You don't have to put up a Excel sheet, but that particular committee reports can auto-generated through the system. All the IHI tools are embedded within the system. Automated risk registry is also available, so that all the responsible people who have to manage the risk are auto-alerted on any action that is pending. Then you have the key performance indicators, where all the data touch points are integrated with the key KPI and clinical indicators formula, so that it automatically generates the KPI and CI, and the dashboard will be populated, especially for clinical indicators. Data analytics is part of the digital transformation, incident management, complaint management, NPS, project planning. If you have any particular project that is being undertaken as part of improvement, that will also be captured, and there is a separate section for project planning. Then you have the audits, any type of audits. AMH was accredited by ACHS and Diamond accredited for the last 3 cycles by the National Accreditation Body. We are also accredited by ISO OSHAS and ISO 9001, which is a QMS system. We have the medical chart audits, which I will explain how many audits have been conducted through the digital platform. We have the CUSP and IPSG. We have the infection control, where all the elements of infection control is automated through the EMR, as well as through directly integrating with the equipments that capture vital data. And staff competencies training program is completely automated. I will show you the screenshots of some of these. So types of audit that were digitized is in the CUSP area, 11, in the IPC 7, in the TRIP 2. In the customer satisfaction, there were 12 audits that is digitized. Customer satisfaction in patient area 2, education 4, and infection control and complaints 1. So usually there are challenges in the digitization process and in the transformation strategy because people resist to change. So what are the challenges that we faced is digitization, the CQI framework, all the audits were manual. So converting that into a digital took a lot of time. Even though our total time frame was only 6 months, it was hell of an effort by the entire team. Audits were not timely. Most of the audits were not happening timely. No control on auditors and their frequency of audits because you don't have a data on how frequently they do the audit. You have seen that it will take 30 to 40 days for us to get a feedback on the audit. Duplication of data, data inconsistency, transparency of data. Establishing a patient safety culture within the organization, less anonymity while responding to safety culture surveys. Medication safety audits not efficient due to data validity and reliability issues. Patient identification audit done was retrospective. Creating live dashboards, data is not accessible. Data analytics was very difficult because of the Excel-based system. Decision making was delayed. Inconsistent analytical dashboards in Excel sheets. Creating outstanding patient care experience, manual feedback that takes a lot of time for analytics. Delayed action and communication within the organization, and service efficiency not measured. So analysis was done through the fishbone analysis methodology. We have identified digitization as one of the problems in the entire framework, process and methods, technical issues, and staff issues. In the digitization, misconception that staff playing with mobile. This is very often being interpreted as staff misusing the technology. Staff attention diverted, especially while doctors entering the EMR. Patient always complains that doctor is not having that eye contact. So this happens in various peers within the hospital and within the clinical space. In the process methods, customize audit based on department, closure of non-conformity. In the technical issues, compatibility of software with mobile, we faced this issue and we sorted it out with the developer. If audit stopped in between, user has to start all over again. That was another problem that we faced during the implementation. The words were small in mobile, difficult to learn. We overcome this particular issue by referring to the WhatsApp because everyone is using WhatsApp, including old people. And the excuse that the words were small is actually overcome by people when they are in need of communicating with the public or to their relatives. So it was easy to fix this particular issue. Staff issues, staff not familiar with technology aspects, a lot of training was required. We created a WhatsApp group for different groups within the organization that provided support 24/7 because this is an inpatient facility. Personal mobile data wasted. That was another issue that we were managed by having hospital provided mobile phones and PDA devices. Fear of patient complaint because of the technology, overuse of technology. The status of issues, we managed to close 10% of the issues. Future feature was 10.8%. One of them was recently implemented, which was the antimicrobial stewardship. And for discussion, 44% were for discussion. So 32,000 audits were conducted. 36 types of audits were conducted. 1.1 million questions were asked during the audit phase. Staff engagement, 97% clinician participated in staff engagement, which is a very high percentage, and 100% nursing. Time saved is 4,200 hours, which is calculated based on the total man-hours that was pre-implementation of the digital transformation and post-implementation. Time to address less than 24 hours, as I explained in my previous slide. Management view, it is a single view management dashboard that is available to various management groups. Improvements and innovations initiated. There are 20 innovations and improvements initiated. And all of this was completed during COVID within 6 months from the start date of the entire project. So manual to practical took only 6 months only because of the team effort. And the most important person who was part of this entire implementation is listening to my presentation, Mr. Jayendra. These were some of the screenshots of the learning app that is embedded within the iBar system. So all the learning was happening through the learning app. So it is either recorded or live learning experience. The alerts will go through the system that today there is a learning session that will be happening through the digital platform. So wherever they are at work, they can open the app, they can access the learning experience. Mandatory training will have to be accessed by the staff and they have to complete the entire competency metrics after the training. This is the monitoring dashboard that is available to various team leaders and management. This is a surveillance tool that is embedded within the system. So we used a NPS score system from Survey to Connect, which is a very popular app that is currently used. So that was the only other system that we have used. Dr. KAVITA was mentioning about integrating various systems, without which you will not be able to create a very good digital transformation experience. So we integrated this system with our iBar system to create the dashboard of the NPS score. So you can see a departmental wise NPS score here. These are some of the dashboards for patient chart based compliance, departmental compliance. So this is the live dashboards that is available to various type of management groups. You can see the risk metrics here. So you can see how many items are in the red, how many items are in yellow, and how many items are addressed and within control. So if you look at the entire accreditation process, what we have done is we have created the elements of NHRA accreditation requirements into various audit compliance. And all these audit compliance are created in a single dashboard where you can see what is the achievement for each of these audits. And then you can click in each of these audits and see why the compliance is low or how we are achieving high compliance. And here you can see the audits of various systems. You can see the assess audits system. And here you can see another type of audit that is being displayed in a digital format. These are the service line head. They can see within their department how many complaints are there, how many incidents are there. They can further drill down within the incidents. What are these 11 incidents? Who are involved in the incidents? What is the current state of the address of these incidents? So all of this can be controlled within a single screen, from where you can further drill down and see what are the details of each of these. So these are the alerts that is prompted through either WhatsApp or messages, or even through the IBAR system. So a new incident is prompted, then everyone related to that incident will automatically get an alert that they have to start initiating the action. See, these are the audit with the use of the PDA devices. For example, this is a hand hygiene audit being anonymously done by the auditor with the help of the handheld device. So this project is an award-winning project, along with the next success story, which is the next presentation. So we have won the best project award during the National Health Regulatory Authority competition. And in conclusion, I can say that the staff empowerment will happen through the digital transformation. Management will get deeper insights into the entire operations, both the non-clinical as well as clinical. And the digital tools will really help the entire employees to provide a much better patient care for the entire patient population. And digital leadership is the buzzword. As we see that AI is the buzzword. So what are the good qualities of a digital leader? Foster economic growth, promote innovation from digital development to digital transformation and entrepreneurship, and improve service deliveries without sacrificing the humanizing factors of compassion, grace, and love. As you know, without data, you are just another person with an opinion. Nobody will listen to. In God we trust, all others must bring data. That is from Edward Deming. I would like to thank Jayendra Tripathi, who is currently working as a management consultant in our company, but he was heading the entire implementation with a very strong team of around 70 employees within the group. Deepinder, he is the superhero who created this group and who has been giving opportunities for everyone to share knowledge. Thank you, Deepinder. And the IBAR team who developed this system over the last 10 years. And their platform has won an award from WHO during the COVID time for infection control software that they have implemented in many hospitals. Currently, they have a footfall of 800 hospitals in India, more than 800 hospitals, and still growing. Thank you so much for patient listening, and any questions can be posted in the group. I can answer. Thank you.
Thank you, Mr. Arun. I already am receiving a lot of messages about your presentation and the software which you're using. So definitely we'll pass on the details to you, and looking forward for your guidance to everyone in the group. Thank you. So we'll now move on to the second success story, and that's from RAGHVI from Bahrain. So Bahrain, just your introduction, and you can go ahead with your presentation.
Good afternoon to everyone. Hope I'm audible.
Yes.
Thank you. So I'm RAGHVI Damodaran. I'm a quality manager working in Bahrain. So basically, I've done my bachelor's in psychology and master's in business administration from Indian Institute of Management. I'm also CPHQ and CPPS certified. I'm also a fellow in ISQA. So recently I got shortlisted as an assessor in American Accreditation Association, but I'm in a training phase. I'm also an internal auditor, certified ISO internal auditor. So that's my background. So quality, I would say I'm a passionate professional in quality. I love the subject. And today I'm going to discuss with you about a quality improvement initiative, which I have done along with my team in one of the hospitals that I worked in. So this presentation is mainly going to be a perspective for the quality professionals about what are the key takeaways in approaching a QI initiative. That's going to be us. So most important, okay, excuse me, Mr. Deepinder, can I share the slide? Is it possible? Because I just, is it,
Yes, go ahead. Yeah.
I'm sorry, 1 minute. Okay. Okay, I think, okay, I've got a, okay.
Look, okay.
Yes,
You can
yes.
share.
Sorry,
Yeah, take it out.
Is it visible? Yeah.
Yeah, we got it. Thank you.
Okay, thank you, thank you. Okay, so the QI objective is mainly about discharge process. I know the discharge process in many organizations, it is a pain point, and we try to do a lot of initiatives, but still, due to the complexity of the patient care and the different patients that we handle on day-to-day basis, there is always problem, and we try to find out the internal threshold. When we started this project, the first thing is everyone, when we did a brainstorming session, everyone was telling us like, okay, we need to discharge patients within 90 minutes from the time of discharge orders. Another one said around 100 minutes. So how a quality manager in a perspective, how we need to take it forward is to identify, the first step is to identify internal threshold. We can have ambitions, we can have targets, we can have benchmarks, but what is doable based on the capacity of the organization and what is easily suitable, what would be the desired target that we can fix based on our internal threshold. It's what a quality manager or a quality professional first look forward for. So having said that, based on experience in handling many cases, what we understood is like the expected threshold should be 120 minutes from the time of discharge order to the time the patient exit the hospital on the day of discharge. So this is what the wisdom we got based on different troubleshootings and based also on the capacity of our process. So if you could see the overall trends, the month x-axis has the month and the y-axis have the minutes. So near to 120 was our target. So have you seen that, like it was like about to reach 128 minutes. So how did we do that? It was not an easy journey. If you see in-depth variations, these are all the different patients, and there is always target, there is always internal threshold, but there is always variations. This is the truth that we need to agree upon. There are special cause variations. So then slowly the process gets stabilized. So when we approach a quality improvement project as a facilitator in a QI project, we need to first understand leadership expectations, set clear targets, what leadership expect, and understand the team dynamics. I know many of the experienced professionals have joined here, but still we have quality managers and quality professionals also join. So this would be the key takeaway to when they go back and do the QI projects. So set the leadership expectation clearly to the team, understand the team dynamics, because people are they are going to help you to achieve the target. And the communication of expectations, and through brainstorming session, we can foster creativity and systematic approach, either through a proper quality improvement methodology, either DMAC or PDSA or focus PDSA. A proper quality improvement methodology will always help us to systematically arrange our timelines and try to communicate with people on the different phases of the project. It always helps. Then the constant follow-ups. As a quality manager, follow-ups are very important. You do a brainstorming session, you discuss with your leadership, you discuss with the key stakeholders in the projects, but if we don't follow up, the project is going to fail. So that's important. And daily reviews of performance. We can use either digital platforms to get the data, or from a hospital HIS or about the data, but daily reviews has to be done based even on the random audits of sample size 10 to 12, or if you have more volumes, up to sample size of 30 numbers we can take for the reviews. And bi-weekly reviews with the meeting with the entire stakeholders and the departments who are involved in the process of improvement are very important to get them updated, like what are we doing, how is our trend, and what we need to improve by this. And the forecasting also, it's very important. Observation on shop floor to observe the organizational behavior factors is very important. How people are perceiving the information and how are they cooperating with you, who are the early learners and who are the performance, how is the mindset of the people in accepting these projects, and do they really believe that this change is going to make a difference in patient care. So that is important. Being a quality professional, we have to be on flow observing these things. And acknowledgement of performance, very very important. Even you have a small incremental improvement, we need to acknowledge it, either in a model huddle meetings or in operations meetings, so that that stimulates the other people to do better and also other units to do better, and also to come forward with the challenges to the operations team or to the leadership on how better we can do it. And these are the problems that I'm facing on ground, and I need this support to make this work. It's doable. So I believe in change. So these are the important things that will come up when we acknowledge the performers. And again, communicating the achievements on monthly basis, or again, a recognition event. So this is what the approach that we took towards it. For this, quality professionals are the drivers for it, because you see different departments work on the different way. Like leadership have their important targets, and nursing have their patient care, operations have their day-to-day troubleshooting, but we as a quality stands in center of it, and we need to coordinate and get this done. That's important for the success of the project. So in this project, what thing I took is Focus PDSA. This is like a go-to tool. Like anything you need, like we can go for this. Like find an opportunity, organize a team, clarify the current process, what is the current state and what is the desired state that we want, and understand the root cause of the understand the root cause of the problem, and then start PDSA. Then you plan the pilot study. Okay, always go, if there is any change, always go with a pilot study with 30 sample size. That is more than enough as per statistical principle. And then implement it, then study the performance, and ensure that it's maintained consistently based on the pilot study, and then implement on full-fledged. So study the performance, act on it, either to go full-fledged or you need to work on it more, and then to further implement it. So this project, we actually did around 3 to 4 PDSAs again and again. So because that required a lot of troubleshooting in the process. Okay, root cause approach. Okay, we have this PDSA, and we have this problem statement with us, and this is what we are trying to approach. But when we look at the problems, and how can we improve the efficiency? How can we achieve that outcome that we are looking for? And what is the systematic approach? What is the evidence-based approach that we can take? When it comes to process, we all talk about efficiency. So one of the important tool in achieving efficiency is to eliminate the waste. So as a quality professional, it's always important to identify the waste in the process, so that we can earmark those things and we can look for action hierarchies, right? So that's important. So this project also, what I did is, like, we looked into I made the team to look into the Timwood concept of identifying waste. Like, is there unnecessary movement of materials and items? Dr. Kavita was talking about process automation. So what are the points that we can look at it to automate the process? And is there any inventory waste is going on? Are we having appropriate consumables for the patient for this package? Is the costing done properly, or is the discharge plan done properly? So how much of waiting time is there? So basically all those problems have been categorized into different waste. So that made the team to understand, okay, there is a concept like this, and these are the different waste that I have in the process. If I could eliminate these waste and the non-value added steps, my process is going to get efficient, and I can do it in the time that the organization has given for, and the patient's also more happy about it. So this concept is very important when we work on the QI project. So mainly, what are the causes that even we were having this as a quality monitor, but people were not knowing about why this is not having performance, and what am I doing? How is my unit performing? So that lack of awareness about the target was there. Because believe me, when we told them, when we make accountable of the each unit managers, I'm talking about the patient care units, the nursing supervisors, the billing and the insurance people, and even the medical director, we tell them that this is the target that we are looking for. Everybody's attention is towards that. So that's an important point when we have a QI project, that awareness about the target is important. And lack of accountability. So we have responsibilities and accountabilities. We have to ensure that we give them accountable. I'll show you some sub-process slide that I have. This is the sub-process that we have, and this sub-process have to be completed within 10 to 15 minutes. And if it does not happen, then it is accountable. It's not like fault finding, or it's not like, okay, you will be blamed. No, not at all. It's like making them as a champion for that sub-process. Then care plan optimization. We found a lot of patients, referrals were done at the last minute, investigations were done at last minute, then even physiotherapy sessions were done at last minute. And some patients were made to stay till evening to reduce the average length of stay, so length of stay. That also directly correlated with the average length of stay of the hospital. So the care plan optimization was also done with the help of evidence-based guidelines and the clinical care pathways. Well, we didn't have the decision support system at that time, but still we took the top 3 conditions and the diagnosis, which are the procedures with the patients are getting admitted in our hospital. And we had a discussion with a group of doctors, and we told them that this is what we are looking at, and these are the problems. This is the percentage of patients, those who are getting discharged exceeding more than 120 minutes. How can you help us? So they were involved very much into it, and they optimized care plan. Referrals were done the previous day. Physiotherapy sessions were done previously or in the morning, on the morning time of the discharge. All those things were happening. So doctors were giving ample support in the successful implementation of this project. And sub-processes delay, as I told you, that we addressed that also. Then unnecessary movement of manpower and documents. So this is where we took an approach of process automation. So with the help of EMR also. So the example, once the discharge summary is ready, the healthcare assistant has to go to the pharmacy and give the slip, wait there for some time and get back the medicines, come back to the ward area. So this is what the process that they took around 20-25 minutes. So we automized it. I'll tell you in the next slide, like how we did that. So this is also the causes which has contributed to the discharge, delay in discharge. Billing and insurance approval. Obviously, this depends on the policy of the organization. This is very sensitive and depends on the insurance and understanding with the companies. So what we had is like, we don't make the patient to wait for insurance approvals. We know that based on the previous record that these are the companies that we don't have troubles with. So we took that leverage, and we actually on case-to-case basis, we approach these problems. But believe me, this is not, these problems were not the peak in the causes of discharge approvals. Our main problem was about care plan and the patient side delay. Human error in discharge summary and patient side delay. Patient, even after paying, they will not go out of the room. Unfortunately, we didn't have any holding area, or we did not have any waiting areas for them. So we had to hold back the patient in the room. So that was also the most important cause for this discharge delay. So these are the various causes based on the hospital setup that we faced and that we worked on, and we categorized as per the Tim Wood. So process efficiency, this is what I wanted to say. These are the sub processes that we had, and this is how we when we had the brainstorming session, when we spoke with them for each and every sub process, this is how we fix targets. Like, for example, doctor rounds to discharge planning. The doctors have to visit the ward before 9 o'clock, and they have to give the discharge planning on the day of discharge. And from the discharge planning to summary formalization, it should take an average of 50 minutes. Sorry, it should be the target is down here, but this is the current average that we had at that point of the time. So we made the team aware about how these each and every time is getting accumulated, and it is getting affected on the overall. It's like a snowball effect, right? So that's how we made the team to understand. Then on month 3, what we did is we also put in the range, we put the average, and what is that we are looking at. We fix the target also. So when we have these sessions, it's just not the overall discharge process, the turnaround time it took. It involved sub processes turnaround time. So in that way we approached, and that way made the people accountable of their units, and that way we get to know the further causes, and we troubleshooted problems. So how did we troubleshoot problem? Okay, so many of us know that IHI has given action hierarchy as a part of RCA Square, but it just not only applicable for the incident reporting process, it also applicable, we can make it applicable on this improvement process. Okay, so stronger actions, this is an important role of quality managers to get updated about the recent evidence-based guidelines that we have on the improvement initiatives for the process excellence, and implement those things in the ground so that you will know that how the system is behaving. So having said that, we always looked at how we can automate process, how we can have reliability on system more than human. So so that's what the approach that we had. So as per IHI, these are the stronger actions with the action hierarchy. Simple is like less human reliability, how much you can do automation, digitization, and how can you eliminate some unnecessary processes so that your ultimate goal is achieved. And intermediate actions, they have given all those things, and you have weaker actions. So more reliable on human, it gives that more number of weaker actions. Your projects are high likely to are not able to achieve the target. But if you put the system reliability, it's going to give you a lot of difference. So what did we do to improve the process? We did discharge planning. We made discharge planning as mandatory field during admission. We were using EMR, electronic medical record. So discharge planning is a mandatory column in the admission, so that every doctor have to update the average length of the length of stay. With that system gets automatically calculated the discharge date. So that's what we did. And timely discharge alert. If the day of discharge is going to be tomorrow, the doctor will get the alert today, just 8 hours before, 6 hours before. So if the patient is not, the discharge is not ready, the doctor will get an alert of modified discharge plan based on the modified care plan. So that's what the timely alerts we created in EMR. And process automation. So as I told you, the movement of the slip from the ward to the pharmacy and then going back to that. So we implemented something called as a whiteboard with the help of our IT team. So this whiteboard is reflected in most of the department units who are involved in discharge. And this whiteboard will show which are the patients who are ready for discharge and what is the status of the each sub process, which I showed you now. Is it open or closed? Is it done? So that next step is getting the medicine. Okay, so then the pharmacy manager will know that, okay, I need to dispense the medicine. She opens the EMR. Already we had CPOE, so they take it and they send across the medicines directly from pharmacy. With this, we were able to take around 10 to 15 minutes from that. We did not have pneumatic chute system, so this is the only way that we can go with. So that's a one thing we did, process automation. Then whiteboard implementation, and we also made it a habit that it should be a cutoff time should be 12 o'clock. The patient have to walk out of the room at 12 p.m. so that you can take your patients who are waiting in ED for the admission, and also the new admissions can go in. So this is also a kind of an alert that we had in the system. These are all like helps. These are all human factors which help. It's kind of a triggers which help the team to move forward. It's kind of a push that we had. So related to human reliability, we requested doctors to have early rounds, but we had challenges, but it was like a very slow progress because they had their own explanations of why they are not coming for rounds at 9, because most of the surgeons, they have to be going for OT, some emergency cases. So well, it's understood. We always kept it at last. And residents were encouraged to prepare the discharge summary at the time of discharge. Do not do it at the day of discharge. Do it from the beginning of the admission so that you can update your history, you can update your diagnosis, differential investigations, course in the hospital. You can write it beautifully and draft it so that at the day of discharge, you have to just go through, get it signed from the primary consultant. So this is where advised. And pre-planning for the packaged patients, basically a previous day, we ensure that we keep everything ready. So the next day morning, doctor comes in, do the checks, and they can good to go. So we were able to discharge most of the patients by 10 o'clock, 10:30, like that on the day of discharge. So these were the few plans, obviously, optimization of care plan, as I told you. With the less resource setting, how can we do? We cannot just blame the management where we want to buy that, this, that. We all know that we work on a budget. So what can we do to optimize, and with the availability, how can we make it work? So that's what we were trying to do. So whatever we could do, we did. And with the help of accountability and giving proper accountability to the team, we were able to make it done. And most important thing, which is a pain point even we had, is how do we convince the patient to move out of the room in spite of regular follow-ups. They did not, because this part of the world, especially in GCC, patient take their own time, and we cannot force them on, and they are ready to pay even for extra charges. So that was a challenge. So as quality professional, we need to look for various papers, look at what are the trends, what are the research findings that we have. So I happened to see this study. This was an NHQ. So we got to know that, okay, patients and families were made aware about EDD, estimated date of discharge, from the time of admission. So usually hospitals have a whiteboard where the nursing team writes in that, okay, discharge plan is that, but we did not have whiteboard because it affected our aesthetics. And what we have all we had is the IPTV. So with the help of IT, we were able to fix the IPTV, and through whiteboard, we were able to display the estimated date of discharge in the patient rooms. So yeah, well, that did not give that much of effort, but it was helpful. At least we get a satisfaction. Okay, we did our job. Like, what we can do more than that. So the counseling, effective counseling, were also being encouraged. So that's also there. So in this journey of 6-7 months, we faced a lot of challenges. It was not a cakewalk. It was not easy. As a quality professional perspective, I'm talking about, because they were under reporting. We did not have a proper report, because the sub process which I showed you, everything we were not able to capture because some was not counted in the EMR. So you will not be able to pick up fields, right? So without these kind of software. So under reporting of delays were there. Sometimes the data was skewed, and sometimes we were not able to understand why this system is showing this pattern. So that's where the quality manager has to go back and study again and capture these under reporting. This is important, that we had this problem. and lack of timely leadership, because leadership, as you know, quality is just not their job. Quality is also, they walk the talk, but there are problems, day-to-day troubleshooting, and they sometimes they'll not be in office, sometimes their focus is on something else. So sometimes the timely leadership support is not available, was not available. So what happened is, instead of making it happen quickly, it took at least a week to make this work, right? So that is the problem that we had. And reluctant to change, that some people did not believe that, okay, is this really going to help us, or when the starting stage, I mean to say, every QI project, that's what I tell my team also, believe in the change, it's important. Don't think this is an unnecessary thing. Everything is going fine, but why you need to do this? Because this problem is frustrating for you, and you don't have beds to admit the patient. So obviously you have to believe that this is the component that's going to make you that make the system change. So this is what we need to make it. It has a lot of organizational behavior aspects that we had to face, especially with team dynamics and interdepartmental coordination. Yeah. So reluctant to change was also a challenge that we had, and lack of motivation, obviously it comes the way along. And manpower challenges, obviously budget challenges, all those things is a prevailing condition. So these are all postpones your incremental improvements. I believe in incremental improvements rather than making it work on one day, because then only we can maintain and go ahead and consistently. Yeah. So that's it about this QI initiative. The main reason I shared is like, okay, from a quality manager perspective, okay, these are the problems that we had, these are the approaches that we took, and it helped to, do better. That's the thing. Anybody has any doubts, you can ask me. Otherwise, thank you so much for listening.
Thank you, Raghvi. Thank you so much. Really appreciate it. And it's very impressive project that you had just shared.
Thank you.
Great. So we'll be waiting for the questions in the chat box later on, and we'll just lastly move to the presentation, which is going to be by Dr. Samia on the awards, upcoming international and national awards. Over to you, Dr. Samia.
Thank you, Mr. Deepinder. Good afternoon, and a warm welcome to our distinguished JCC healthcare leaders. Thank you, Mr. Deepinder, for the opportunity and for creating this platform for knowledge sharing. So I'm Dr. Samia Filali. I'm Director of Quality at Royal Health Group, Sheikh Rehabilitation Hospital, located in Abu Dhabi. I'm a medical doctor by training, and with more than 25 years of experience in clinical care. I'm holder of 2 executive masters in analysis and healthcare management, lean management certified, CPHQ certified, ISQA fellow, and CARF international surveyor. So it is my pleasure to present to you the upcoming regional and international awards. As you know, these awards are more than just accolades. They are an inspiration to all of us. They remind us of the height we can reach when we push the boundaries of what is possible, when we innovate, and when we strive to make a positive impact. So we gathered some of the regional and international awards as example, as follows. So first of all, we have some example about the regional awards, as you can see here. So we have gathered some examples. If we take one, for example, the Sheikh Khalifa Excellence Award. So the Sheikh Khalifa Excellence Award was launched by the Abu Dhabi Chamber of Commerce and Industry in 1999 as a blueprint. It was a roadmap and a methodology for continuous improvement, enhancing the competition of the business sector in Abu Dhabi and the whole UAE. So over the long history of Sheikh Khalifa Excellence Award, since its inception, thousands of organizations in the UAE and the Gulf region used its model of excellence, and hundreds of them annually participated in its assessment cycles, and many of them were recognized as a recipient of this award. So the Sheikh Khalifa Excellence Award is the program is actually your partner and strategic supporter in availing you with the state-of-art tools and techniques needed to help in your request for achieving people developments in terms of knowledge, skills, and attitudes, and also a system development in terms of efficiency and effectiveness, and hence achieve the desired results. Moving to the international awards. Next, thank you, Mr. Dipender. So also we have gathered some example from the international awards. If we pick some, for example, the International Hospital Federation Awards, the IHF, it was launched in 2015. The IHF Awards honor excellence in hospitals and healthcare organizations around the world. During an annual event recognizing excellent project, programs, initiative in hospitals and health service providers across the globe. So the IHF, for example, is globally recognized for its work in the domain of the health field and is constantly reviewing itself to promote cooperation and communication among the major actors in global health. So this federation has a menu of key offerings to its members in various areas of healthcare, in line with the modern challenges and issues. So the members are then invited to submit nomination for 6 IHF award categories. We can give example as the Grand Hospital Award, the Excellence Award for Corporate Social Responsibilities, the Excellence Award also for quality and patient safety, the Excellence Award for Leadership and Management, Excellence Award for Green Hospitals, and Excellence Award for Health Services during crisis. So it was just a brief citation of one of these numerous awards, and it was an overview of the regional and international awards. For more information, you can consult the site on the provided links. We will be sharing the list of awards after this meeting for your reference. So I wish every applicant a good luck for these awards and wish you all the best. I hand off to Mr. Deepinder. Thank you.
Thank you, Dr. Samia. It's really great to know about all these awards, and we'll be sharing the list which has been compiled by Dr. Samia. With this, we come to the end of the session, and really thankful to all of you who have been sticking together. And we request you to all scan this QR code and give your feedback about what you would like to hear in the next seminars, webinars, and the meetings. This quarterly meeting will be continuing, but we're having numerous master classes and other sessions in the coming days. So thank you so much for your time. Really appreciate it. If you have any questions to ask, you can unmute yourself and ask. Otherwise, we'll be ending the session in the next 1 minute. Thank you so much. The chat box answers to those questions are there, that yes, we will be sharing the recording of the session and the presentation and the list of awards. We have taken the permission from all the presenters, and I am very hopeful that this will be helpful for all of us. We learned a lot from each of the sessions, and I really thank all of you, all the panelists. So Dr. KAVITA, Mr. ARUN, RAGHVI, Dr. SAMIA, Dr. LIZA, Each one of you have really contributed very well. They're not simple things, getting time out from your normal day-to-day routines and bringing all this to the forum. So we look forward for your continuous support to this group and insights to the industries. Thank you so much.
Yeah,
Thank
thank you,
you.
Deepinder. Thank you so
Thank
much.
you.
And thank you all the speakers. It was wonderful associating with all of you. Bye.
Thank you,
Thank
Dr.
you.
Kavita.
Thank you.
Thanks. Bye.
Thank you.
Thank you. Thank you, everyone. Thank you.
Bye.
Thank you. Take care, everyone. Thanks. Bye-bye. Bye-bye.
Take care. Bye-bye.
Thank you. Bye-bye.